All right, that brings us to Cindy Mann. Cindy, thank you so much for joining us. And first question to you is, how does, we're talking here about large scale policy change at the state level. Medicaid is obviously a huge tool that states have, a hugely important program for the health of its citizens. How should states think about Medicaid as engaged with this kind of systematic reform that they're undergoing? And I think you might want to unmute.
Unmute. Thank you for the question. Thank you for the opportunity to participate. So, I think that Medicaid has a strong track record already, but I think the opportunities, and as indicated by the two speakers, really are much broader than where we've been so far for quite a while. And I give Medicaid writ large a lot of credit for this, meaning a lot of actors at the state level. There have been more aggressive efforts to build in social drivers of health into that care package, and to really integrate social drivers of health inside the delivery of care, so that it's whole person, and so that we're really thinking about buying health. But it's been episodic, it's been pilots, it's been smaller scale, it's been waivers, and we can talk about some of those. And of course, you learn a lot from them, but I think there's a lot of energy now to go beyond that. And part of that, of course, is spurred on by COVID, and by how clear it became to everybody in the community, in the healthcare system, and community-based organizations and otherwise, that unless we start treating the whole person authentically and not just talking about it, we really aren't going to address some of the health issues that COVID was revealing, and certainly some of the equity and disparity issues that COVID wasn't the first to reveal, but shone quite a sharp light on it. So I think we're really at a juncture where there's a lot of states, and I think some interest at the federal level, to harness that energy and to harness that collaboration, and to think about going to the next step. So if I can talk a little bit about how do we move forward, and I think it's very much along the lines of what Ina and Donna have talked about, in terms of really going to more of a global budget approach, more of a universal approach, whether it's hospitals, whether it's all providers, whether it is all payers or just Medicaid. Obviously, advantages going as, in my view, going as broadly as you can, but each step can really contribute to a different way of thinking about financing, and fundamentally thinking about how you buy health and how you can help people be healthier. So there's some short-term but important opportunities. There is a lot of one-time money that's now circulating because of COVID, and that did certainly help spur some of these efforts during COVID through the CARES Act, and now we have the rescue plan. So that the challenge, I think, for state Medicaid programs and other players is to think about how to use those dollars to build towards the future, to set the seeds for establishing the relationships, the system, the planning, as well as providing some of the services. We also have a new administration that's at the federal level that's very interested in the drivers of health and how we can change the financing system of our healthcare financing system to support it. And some steps that they can take can really make Medicaid dollars flow more to address some of the items that need to be paid. Some of this is as basic as service definitions, what can be paid for in Medicaid, how to think more broadly than how we've thought about it in the past. Some of it is other levers in the Medicaid program, like in lieu of services. We pay a lot of money sometimes when a homeless person is sitting in a hospital, and the alternative to discharge is sitting in the hospital, but discharged to the street, so that we pay for sitting in the hospital for a while. That's not moving the patient along. That's being empathetic about not discharging them onto the street, but how can we think about services in lieu of that hospitalization that Medicaid can pay for, that can be built into the rate setting mechanism to say, no, let's think about some housing solutions rather than sitting in a hospital. And of course, there's a lot the administration can be doing to really beef up the opportunities to do those kinds of initiatives in the Medicare program, which are sorely needed. But to go beyond the expanding service definitions and for services that don't neatly fit into that structure, global budgets based on total cost of care can really provide the flexibility for funds to be used wisely for cost-effective innovations. And you can do lots of different models. You can do global budgets at the state level. You can do global budgets at a, all payers throughout the state. Your example, Josh, of 100% in Medicare, in Maryland, I'm sorry, of people being able to be in that system. You can do it at all hospital level so that you're not paying different ways of paying for based on Medicaid or Medicare or private pay. And you can do it at the plan level. And I know besides the states here, I know of other states that are thinking about it at all those different levels. The concept is similar, the scale is different, although important to note that the whole is always more than the sum of its parts, right? And I think as Donna noted, when all the signals are aligned across the sectors and the payers, the ability to move that needle is certainly enhanced. So the idea of a global budget and looking at total cost of care is that you've got the flexibility, whether it's at the state level, the hospital level, the plan level, to use that money wisely to buy health and not just to buy health care. So the favorite example is if buying an air conditioner can avoid the asthma readmission, a health plan with a global budget is going to buy the air conditioner and make that decision because that makes sense in terms of total cost of care. And they're not losing money at the other end because their global budget financing allows them both the flexibility and the protection to know that they have a reliable way of financing care. I do want to say there's a couple of cautions and caveats that we all have to pay attention to as we continue to move into this space. One is in Medicaid, if it's not in an all-payer system like we had in Maryland going into it, Medicaid payments can be lower than other sectors. And how do we turn a global budget that uses Medicaid as a base to be sufficient to really handle the broader array of care and services that people need? We also another caution is there's concern about utilization and underutilization in global budgets. So Maryland, and we've been looking, and I know some of the work that I've been doing, I've been looking closely at what Maryland's been doing to protect against underutilization, to make sure that the flexibility moves us forward in terms of people getting healthier. And there's also issues of equity. We know now that certain parts of the population, whether it's by race and ethnicity, whether it's by diagnosis, whether it's by age, don't get the care that they actually need now. So if we're trying to reduce care, right, and we might have the wrong baseline for some populations, and we might want to really think more expansively about where there's been underutilization of key services and by key populations. And to do all that well, we need good data, good quality measures, and our tools are not yet sufficiently refined. The other thing I just want to mention is the concept of total cost of care is based on a notion of return on investment. And so the asthma example explains that you'd use the air conditioner to prevent the hospitalization of kids who've been going in repeatedly to ED visits because of asthma episodes of asthma trauma. But there are folks that need those services and whose health depends on those services, who aren't high utilizers of our healthcare system. So we have to think hard about that. And does the global budget serve those that's based on total cost of care? Does that work for that population? Or do we also need supplemental and complementary financing systems to go forward with it? We've worked on a concept, for example, for kids who are generally healthy, to do children's health and wellness funds. So maybe within a global budget, there's also a contribution that is put aside for populations that may not be high utilizers, but for whom you also want to make sure that the idea of building their health and not volume, and not just reducing cost of care is important. And, and finally, in terms of caveats, there's lots of things that are going to be beyond the capacity of even a financed and incentivized healthcare system isn't going to be able to fully support, which is long-term affordable housing, for example, which tends to be very expensive. And when I've worked with health systems looking at total cost of care, there's something they can do for housing, but only for maybe the top 1 or 2% of utilizers. Otherwise, the equation doesn't work.
Got it.
But the bottom line is there's much to be learned. I'm wrapping up, Josh, from Vermont and Maryland. And there is a really growing appetite to be freed from not just volume, but even of services, but really even the value to buy health. So I think there's appetite at the state level. I think there's considerable appetite at the federal level. And I think there's really a way to take these global budget initiatives and really move them in scale across the country.
Thank you. Thank you, Cindy. And I hear you saying both that Medicaid can be a partner in the sense that Medicaid participates in different ways in the models in these states and can actually be a real partner at the table for system-wide transformation, but also Medicaid can be its own little lab for innovation, particularly in the kinds of things that Medicaid dollars can be used for, and the kinds of flexibilities that might go a little bit beyond health care traditionally, and start to push deeper into some of the social factors in health, and through that spur even more fundamental reform.
I think that's right. And I think we've already seen Medicaid really, and it's, as they say, you've seen one Medicaid program, but it's really been a leader in a lot of this area. And then particularly during the COVID time. So I think there is a lot to learn, but I think there's a long way to go for Medicaid as well as for the larger healthcare system.